All right. It's 10 o'clock, so I am going to get us started. Alrighty. So, hello and thank you everyone so much for being here today. My name is Emily Steinberg, and I am the new communications coordinator here at Ohio Suicide Prevention Foundation. And I am really excited to present our webinar for today. Our October OSPF webinar is called Bridging the Gap: Mental Health Services for Individuals with Developmental Disabilities. I'm very excited to welcome Lynn Siegford, a supervisor in the Community Services Department with the Mahoning County Board of Developmental Disabilities. Welcome, Lynn. Thanks for being here.
Thank you so much for having me. I'm really excited to present today, um, Bridging the Gap, because that's definitely what it is. It's what I
Yeah.
see on a daily basis. In my role as an SSA supervisor, I supervise a wonderful group, amazing group of 10 SSAs. I don't know how many people have dealt with the DD system or have individuals that they work with within our system, but each of those people carries a caseload of up to 36 or 37. I am one of 5 supervisors, and my specialty area is behavior support, which often is the area that receives all of these referrals and information about people with
Mhm.
mental health issues, and specifically suicidal ideation, suicidal attempts, and what happens after that.
Yeah.
An SSA you can think of as a case manager for services for individuals identified as being eligible and or receiving services
Great.
from
Lynn,
the
do you want to go ahead and pull your slides up and I
I'm going to do
can
that right now.
share your bio with all of our participants? Also,
Okay.
before Lynn gets started, I do just want to take a moment for a housekeeping detail. So after today's webinar, you're going to receive a link to the post-webinar survey evaluation. This survey is required for those of you who want to earn continuing education credits or a certificate of attendance. All certificates will be sent within the next 30 days. So let me introduce Lynn. I'll read through her bio and then I'll pass it over to you. So
Great.
Lynn, as Lynn mentioned, she is a supervisor in the Community Services Department where she provides supervision for service and support administrators who provide case management and coordination services for individuals with developmental disabilities in Mahoning County. She has continued to evolve her career over 38 years of employment with the Mahoning County Board of Developmental Disabilities, has served as a speech and language pathologist and therapist with school age population. She's worked as a communication consultant with the Adult Services Program and habilitation coordinator for the sheltered workshops and retirement program settings previously provided by the board. She's also partnered in the development of a community employment program and curriculum called Opportunities at Work and holds an MBA from Youngstown State. Among recent accomplishments, Lynn also serves as a liaison to the probate court and the behavioral health services unit at Mercy Hospital and is actively involved in trauma and resilience training and the Stand, Grow, Thrive cohort in the Mahoning Valley. Lynn is trained in sources of strength curriculum and advocates for wellness and self care for every individual. She has also served as a field supervisor for the Cleveland State University School of Social Work. So, Lynn, thank you again for being here. I'm going to turn my camera off. I'm going to hand it over to you, but I will field any questions in the chat and jump in with those throughout. And then at the end, we'll have a formal Q&A as well.
Okay. Thank you.
Yes, ma'am.
Okay, so we're going to get started talking about bridging the gap, mental health services for individuals with developmental disabilities. Um, and okay, so our learning objectives today are we're going to learn about the structure and services of Ohio County Boards of Developmental Disabilities that serve individuals across all 88 counties, identify the prevalence and implications of dual diagnosis, which is intellectual developmental disabilities and co-occurring mental health conditions, and then evaluate available community resources, including successes, challenges, and gaps in services for individuals with intellectual developmental disabilities and mental health needs. Here is the lovely state of Ohio. There are 88 counties, each county having its own board of developmental disabilities. Some counties, the smaller ones, may actually share a superintendent. They may have a board that they share. However, each of them operates under Ohio Revised Code and state rules. Each of them does have a community services department, regardless of what they call it, like ours. As of 2023, county boards are no longer allowed to provide direct services to individuals. So we provide service coordination through our SSAs or our case management, along with some other things. Some of the counties do still operate school programs, early intervention programs. Many counties got out of the business of school programs quite a while ago as well. Integration and inclusion is a thing that is promoted, and some counties have units in school buildings, but for the most part, we don't do any direct services. There are approximately 100,000 individuals served by these boards. And about 33,600 individuals are children aged 3 to 17. 8,000 are young adults aged 18 to 21. Here in Mahoning County, we do operate an early intervention program, which has now been taken over by the Department of Health in terms of the regulations. However, we serve children, plant services at birth, and our oldest individual with disabilities that we serve just passed away at the age of 99. So we are definitely a birth through end of life supportive agency. We're a local public agency. This is true for all county boards. We advocate for needs of people with developmental disabilities and their families. We ensure needed services through funded programs such as Medicaid, waiver, and county funds, and we provide referral and linkage to available resources. The county boards of developmental disabilities were established by a state legislation in 1967. They used to be called the 169 programs, and the role being providing local services for individuals with intellectual and developmental disabilities. Before this, services were often limited or located in institutions. It changed the focus to community-based support, and really are allowing and promoting individuals living, working, and participating in their local communities, no longer sending people away to places. I'm not sure of the average age of our participants today, but if you wanted to, you could look up Willowbrook, you could look up Apple Creek, you can see the treatment that people received. You know that historically, parents who had an individual with a disability, including something that we don't really think of as severe, like Down syndrome, cerebral palsy, were encouraged to place their children as soon as they were born, because they would never have a normal life, would not develop or grow into anything worthwhile. And so that is the way people were served. I can spend a lot of time talking about Mahoning County. I'm sure every single county has its history. But the history of boards is rooted in local efforts by parents and citizens. Here in Mahoning County, we had parents who took turns having children come to their homes, providing things for them, eventually taking over a small building and hosting a school there, until the building that I'm sitting in right now, our local school, which we have a part in, was built in 1969 and continues to serve students here from Mahoning County. So we have really developed, along with the changes in society, excuse me, medical changes, and the way that people are viewed and included, which is truly a civil rights issue. If you really wanted to debate that, I could go on. So in order for someone to be eligible for services, the general eligibility is the age of onset. The disability must have manifested before the age of 22. So it doesn't mean you have to be born with that disability. We serve individuals who, a young person who I remember getting on my caseload, was headed to her first day of nursing school, was in a horrific car accident, traumatic brain injury, then developed lots of other issues. She was served, but lived a typical life until that point in time. The type of disability is the individual has to have a disability other than a sole diagnosis of mental illness that's severe, chronic, and will likely continue indefinitely. And they have to live in the county where they're applying for services. That's recent. You could apply for services at any single county in Ohio. You'd be on a waiting list, and you would say, "Okay, I'll take that spot." But you have to live in the county where you're applying for services now. So someone who has a learning disability, ADHD, someone who might have lower cognition, we no longer really look at IQs. We look at a variety of things. So just because someone has cerebral palsy doesn't mean they're going to get our services. It's a medical diagnosis, but how does it manifest themselves? What we're looking at is significant functional limitations, which you see at the bottom of this slide. There are 7 life areas: mobility, communication, ability to live independently, ability to manage your finances, self care, and self direction. And so, through the assessment, a demonstration of having significant functional limitations must be present. I often have conversations with my staff and others that I know people in the community who function in the same level as someone would think would be eligible for services, but they manage to drive a car, they have families, they go to work, they live a life that is a good life for them. It doesn't mean that they qualify for services because they have a low IQ or because they have cerebral palsy. There has to be an intellectual disability. Some of the other disabilities are autism, CP, certainly, which I've mentioned, Down syndrome, other physical or co-occurring mental impairments. We have Fragile X syndrome, Frederick's ataxia, a lot of you know, different names and labels that we know. There's cognition, developmental delays, and those issues as well. And so, eligibility is an assessment. Someone could be determined eligible for services, and then they do qualify for what county boards can offer them. Excuse me. So I talked about county boards and what we offer. So we have service and support administrators. County boards actually are a fiduciary. We authorize Medicaid funds. That is the typical payment, the typical funding source for people. County boards can fund things on their own. Um, I'm telling you the way of the world. Here in the state of Ohio, we know that we're dealing with a strong forum of people who feel that there should not be property taxes. A strong effort to eliminate a lot of the sources of levy money that actually contributes to what county boards are able to offer. So SSAs, kind of like case managers, receive a caseload of the individuals who have the disabilities. And their role is not to do direct services. They don't go out and provide anything on their own. We authorize services and payment for provision of services through certified providers for homemaker personal care, for transportation, for a day program, for community services, for whatever a person needs wherever they are. The environment may be I'm living with my mom and dad. I'm actually attending school, but I need some extra help. I cannot live with my mom and dad. I am in a community setting. I live with two other people in a home that's operated by a provider, and they take care of my needs. I attend a day program because I've graduated. I want to be productive in my life. I want to have socialization. I want to have these kinds of skills. I want to go into the community. These are all services that can be authorized by an SSA. So the SSA's job is to head up the team and coordinate those services for the individual in a person-centered way. We don't say everybody with Down syndrome goes to this day program. Everybody with CP goes to physical therapy. We say, okay, Susan, these are your disabilities. This is what you want to achieve in your life, and how do we help you get there? We authorize Medicaid funding for services, which is a huge thing right now. We locate and link to resources in the community. We respond to major unusual incidents that will become important later on as we continue. And we revise services based on needs. You may be familiar with an individual education plan. We do individual service plans that state this is what I want my outcome to be. This is where I am in life. These are my needs. But life changes, sometimes on a daily, sometimes on a monthly, sometimes someone suffers a setback, sometimes someone makes a great gain. And so we have to continue to change the plans for people, change the services for people as their needs change. And then we monitor those services. That's a great role of what we do, checking in on people. SSAs have a very knowledgeable base of what their individuals are like. This, of course, is developed. I expect my staff to know their individual like no one else. The nuances, things that make them tick, what makes them happy, what upsets them, what are some needs in their life, where are they headed, how do we help somebody have a better life as they move through a journey. So let's talk about intellectual developmental disabilities and mental health challenges. When I first started in this field 38 plus years ago, typical people that I served were kids. I did some language development. In the school, there were 257 people, students, and there were 5 speech therapists, and there were about 10 students who could not talk. We had some people who signed. We had, people with hearing problems. We had people who just could not communicate, starting to use language devices, speech devices, but we never talked about people's mental health. We didn't look at it. Our students saw neurologists. They did not see psychologists or psychiatrists. They did not have counseling. Um, they had behaviors, is what they had. Um, but we know, even though there's a debate, that about 35% of people with IDD also experience mental health challenges. And dual diagnosis is recognized as a significant issue. About 10, 15 years ago, you would get, oh, they have a dual diagnosis. And you're like, oh, okay, that means a whole lot. Now, I don't even think that we identify people as being dual diagnosed. The only time that really comes up for us is when we're dealing with an agency that specializes in mental health issues, because dual diagnosis becomes important. Again, stay tuned. You may know why, but we'll talk about that. I wanted to be able to give some statistics about, attempted suicides in 2020, and this is the data that I have for major unusual incidents in Ohio. There are 1,069 individuals with IDD that had at least one attempted suicide and or unanticipated psychiatric hospital admission. I am sure that has skyrocketed. COVID was not kind to anybody. COVID really was not kind to our individuals. When you think about it, we were upset because we could not go anywhere, places were closed, or we made the decision on our own that we thought the likelihood of getting COVID was strong, that we were concerned that we would get it. And we made our own decision about who we went and saw, what we went and did on our own, and things that were or were not allowed to happen. For our individuals who were in group homes, in community settings, they definitely went nowhere and no one came to them. Family visits were stopped. They could see their parents outside of a window, through a doorway eventually. Staff left. They decided it wasn't worth it and they did not come back. Staff stayed, and when someone in the home tested positive for COVID, if they did not get sent to a hospital, if they did not get sent to a nursing facility, the staff stayed with them in a situation that they did not understand, with gowns, with masks, with gloves, and their whole world stopped. They couldn't go to day program. They couldn't go to Wendy's, McDonald's. They couldn't go to their community events. And that happened for a really, really, really long time. And we are still seeing the effects of that. There were 209 attempted suicides involving 167 individuals. 420 people had a single mental health related major unusual incident in 2020. And for an 8-year span, unfortunately, 18 people with IDD died by suicide. Um, I want to talk a little bit more about that. I will go into, later here in Mahoning County, what I see, what our individuals deal with. I have a young man who has attempted to harm himself in ways that you would think he would have, accomplished dying by suicide. He does not understand what death truly means. He had a family dog who passed away 10 years ago and still asks his mom, when are you bringing Lucky back? When are you going to make Lucky alive again? He truly does not understand. I know that attempts at suicide are cries for help. Um, and sometimes for the people we deal with, it's raising the stakes to get what they want. And what they want is to go to a hospital. Um, and I think a lot of that, I just had a discussion with a couple SSAs yesterday, is we have people who have been in the system for such a long time. We have people who have been involved with children's services and they have been sent to different facilities. One that is used often by Mahoning County Children's Services is a facility in Dayton, there until they're about 17 years old, and then discharged, return to Mahoning County, become involved with our system because they do have a developmental disability. I talked with a young lady one time who doesn't have a guardian, who went to a home where she could be staffed very closely because she would tend to cut herself, threaten to stab herself, and then she would elope from the environment. She would leave. They couldn't find her. She would hide. Um, and she would eventually call 911 and say, I need to go to the hospital. And when I talked with her about it, I asked her, what was it at the hospital for her? And she said it was the safest place she had ever been. You kind of find that hard to believe, but everybody there had a job. They were all busy doing their job, and she never had to worry about a single person coming upon her with something situational that she wasn't prepared for. This house that she was in had two staff, that's for sure, not engaging with her, cooking, doing some cleaning, talking with each other a lot, on their phones a lot, watching TV a lot. And they scared her. Their presence scared her. She now works at a bakery that has knives, by the way. Sharps are no longer locked up for her. She realized when we said, that bakery is probably not a good idea. Like, there's knives there. How can we say she can work with a knife when she has done this? And she's made great strides with a lot of help with her mental health issues. But for me, we like to think we're in the people helping business. So we like to think that we're providing these services and we're really helping people go to a good life. And it's hard for us to actually think that we are actually like causing some mental health issues, or there's a root there that we don't know about because we're so concerned about maintaining health and safety. It was a real eye opener for me. So I want to talk about how we address suicidal ideation and mental health issues here in Mahoning County. I'm sure every county is different to a degree, but an SSA's main role and our function as a county board with the services that we coordinate is health and safety, number one. When I meet with somebody and we're talking about a staffing situation or we're talking about an individual and what they need, it's how do we keep them healthy and safe above all? So, major unusual incidents are things that definitely are major. They're unusual, but they involve hospitalization, they involve the need for medical care, abuse, neglect, those kinds of things. So, we have a 24-hour reporting system. Things get called in, they get investigated, and the SSA works with the investigative agent to make a prevention plan. So it's not like 3 months later we find out that Johnny made an attempt, to hurt himself, and now we have to respond. We are notified immediately. We're part of a team that's trying to work on how do we prevent this from happening again. For example, this has nothing to do with mental health issues, but I had a staff who supervised a girl with Down syndrome. They had a swimming pool, and she was waking up at 3 in the morning and going out and getting in the pool. Fortunately, nothing had happened, but mom couldn't hear her leaving. And so we responded with a prevention plan of, you know, we're going to put an alarm on the door. Mom's going to have a monitor, and the pool is going to have steps. It's going to be locked. Like, that's a prevention plan. Um, for someone with mental health issues, it might be follow up with their psychiatrist, psychologist, and have documentation that it has been done. Um, Meet with the psychologist and talk about what needs to happen for this individual. Share, communicate back and forth. We also do a change of environment. We may have a person who is in a home with three other people, and that's just too many for them. We may have a person who lives alone, and that's not enough for them. We may have a person who is triggered by where they live, has trauma according to, an environment, staff trigger. So we change environments. We put services in place to respond to the change needs. So someone now needs to attend group counseling. We put a service that has a provider bringing them to group counseling. It's almost like a contract. Well, it is a contract where the provider said, I agree to transport this person. And so we make that a service that they receive. Um, anything else that would be a good suggestion from their therapist, their counselor. We have behavior support services. We refer to developmental centers. In Ohio, we lost our center. We are down to, I believe, 8 developmental centers. Individuals from Mahoning County will go to Cambridge Developmental Center. There's one in Gallipolis. There's one in Columbus. There's one in Lucas County. There are 2 near Cleveland. Um, Developmental centers used to be places where people lived, and they were places for stabilization that could take people for a short period of time. Um, but we've kind of lost that. They do stabilization now. A person cannot live at a developmental center if they were not initially in that developmental center. They don't offer beds for placement. We have 6 individuals at developmental centers right now, 2 of them due to suicidal ideation, suicide attempts, who we have been working on stabilization with the developmental centers. One of them, we are looking for placement outside of that center, a place for him to live. They are suggesting that he needs a rural or a farm area to live in. That's not Youngstown, Ohio. We have to find a place and a provider who's willing to serve this young man. Um, he won't stay there. We try to get the best information and carry over as much as we can from that time. But developmental center placements don't really happen in terms of a long run kind of solution. Technical assistance is offered also through a regional liaison. They send out a team of a qualified individual, qualified medical ID individual. They come and take a look at the person in the environment they're in and make suggestions to us as to what they see, what can we try, and we act on that. Psychiatric facilities, again, there are 6 state-run psychiatric places in Ohio, one of them being Heartland, close to us. Um, don't really work for our individuals. People can be ordered there by the court. Um, we have gotten some people who have moved to Mahoning County who have lived in those facilities, often difficult to serve. And we basically respond in that way. We don't have anybody currently placed in a psychiatric facility. And then monitoring, I talked about that. So when we talk about, I'm going to go backwards. When we talk about behavior support services, I have a staff of, I head that department. I have 2 staff. Rules are that they have to either be trained in behavior support, hold a bachelor's degree in some area of psychology. There's so many different kinds of degrees now where there are, behavior degrees and all of that kind of stuff. And they have to have had at least 3 years experience working with someone who has a plan for behavior support. So typical, I'll just share with you a case that we have going on right now. We have a young lady who says that she wants to kill herself. That will bring her, immediately to the hospital where she will sit in the emergency department and be sent back to us. Most recently, she took a paper clip and put it through her navel. Staff didn't know she had done it. She complained of stomach pain. They thought she didn't want to go to school. Finally, she does go to the hospital. She had to have surgery, almost had to lose sections of her colon or stomach area. Um, and, you know, she says, I want to kill myself because I'm mad at the staff or something like that. So she has a behavior support plan. She has services, and honestly, what behavior support does in order to ensure health and safety is we do restrictive measures. We actually, restrict someone's right to something they should be able to have. For this young lady, her pockets, her purse, her backpack are searched every time she comes home from school. The house has every single thing that could be used to pierce, cut, a cord, outlets, light bulbs are silicone. Um, Windows have a special film over them so that they will not break. It will hold them in place. There are no curtain rods. She has a bed that has no screws. She does not have hangers. She does not have a dresser in her room. All the things that someone would typically have. She has plastic plates. She has a spoon that is given to her and locked up afterwards. These are all of the things that we know can keep her safe as hopefully she begins to work through some of these mental health issues that she has. Another issue that she has is internet unsafety, sending pictures of herself, setting up something which we believe would have led to trafficking. Um, so, behavior support services, we will lock up sharps, do room searches, have cameras in place if we have to, have audio monitors in place if we have to. And that's generally how we are handling keeping people safe when they have suicidal ideation. They have made those threats. We have people who will call 911 themselves to get to the hospital. I just had the committee meet, and our Human Rights Committee approved a restriction that a person cannot ever have a cell phone again. She will only be able to use a landline, and she has to be in a room where staff is there to hear her, and staff will dial the phone number of who she wants to call. It boils down to that, in all honesty. Um, Guardians make those decisions. It goes before the court, who, says that the guardian can make that decision. It's not done swiftly. It is not done without consideration of a million other things that can happen. For the one girl, her SSA truly believes equine therapy would be wonderful for her. We're working with another agency who's involved with her to make that happen. But now, when she gets in a car, she attempts to get out of the door. So we've had to install door locks, childproof door locks, to staff because she attacks the staff. Lots of things like that going on, which you may or may not know about, be involved in, be a therapist for, be a counselor for. These are the things that we kind of face. Um, so let's talk about the gap. Oops. Part of the issue with the gap is that expertise is needed, but it's not often available in smaller cities and counties. I got an email yesterday from this fantastic Pathways program out of Cincinnati. Um, our individuals won't ever be able to get there, I don't think. Um, we do have the Cleveland Clinic. I once worked with a fantastic pediatric psychiatrist there, who now isn't there anymore. He went to the clinic in Florida. Um, so when we do have people with expertise, it's sometimes, often it's not available to us in a county. Mahoning County, I always thought of as large. I was informed by my director the other day, Mahoning County is not large, it's medium. Large is Hamilton County, of course, Franklin County is a super county, Cuyahoga County. So availability naturally, like for other things, is, it's more available there. Individuals with intellectual disabilities often are not admitted to treatment facilities because they can't participate in treatment. Um, I am a liaison, I think you heard in my bio, with the behavioral health unit here at Mercy Health, which is the main hospital medical uh, treatment facility here. We have a behavioral health navigator who is actually in that unit, embedded in that unit through the mental health board here in Mahoning County. And I work very closely with him when someone is admitted who we know we have on our caseload. We talk about community plans, we talk about safe discharge, we talk about the need for what's going to happen next. Mostly, people can't live there, people can't stay there. Once they're stable, they need to get out. I have issues with, so this person lived in my group home, and I provided staff for him, and then he went kind of crazy and off the wall, and I don't want to take him back. So you need to find someplace else for him. And then I try to find a place that will take this person straight out of, treatment in the behavioral health unit. The other thing that happens is someone will come into the unit who we're not aware of, and they're absolutely convinced that that person does have a developmental disability. In the past, we would send someone out and do an assessment right there and then try to get them services. Unfortunately, a lot because of funding, a lot because of practicality, assessment involves having documents that show the need, that show diagnoses, that show who you are. Um, and so we can't really safely do that. We can't make someone eligible but not have any information on them. So that kind of changed. What we do try to do is offer support to have whoever is as part of their life follow through to help see if they're eligible for services so we can help them get what they need. Um, but I will get calls and they will say, they're not appropriate to enter here. And I remember a certain point in my life being really teed off about that. Like, who the heck is that doctor there? He won't take anybody with the DD diagnosis. And then when I turn around and look at their way of thinking of things, what is their role? Honestly, what are they supposed to do? Um, Big gap there. And as we talked about, a focus on health and safety can be a distraction to a root cause. Um, I'm so concerned, as in with my girl, I'll call her Dahlia. Um, I'm so concerned about her health and safety that I'm putting extra staff in the house. And the thing that's given her the hard time is the extra staff in the house. The more people I put in there, the less safe she feels, the more she's running away, the more she's acting out. But I'm trying to keep her healthy and safe in the only way I know how, um, by giving her more people to watch her, and not necessarily what needs to happen. And then I used to hate this word. I'm going to use it. We're in silos. We know it. Um, I have many I have staff who have on their caseloads people who are connected to counseling. And one of the questions I ask in my supervision when they come to me with some case issues is, do they have a counselor? Next question, are they going? When's the last time they had a med check? I found out last week that I have a young man. He took a whole bunch of pills, put a knife to his throat, ended up in a facility in Canton, I believe it is, where he's going to be for 10 days. and he's supposed to get an injection every 3 months. And I said, can you please send me documentation of the injections? And what I found out is he does not have a guardian. The provider drives him to the center, and he said, you can't come in with me. And he goes in and he refuses the injection. He hasn't had his injection for 6 months. I said, can you please send me documentation that he had the injection? And all they could send me was they drove him there. They did not send me. Then they said, honestly, we don't know if he gets it because he doesn't let us go in. So we have no idea. Um, the silos are like, why can I not get that information? Now that I found out they're doing that, I certainly have to do something about it. But there was never, I don't know, is there a release of information? I have to find out. And then are we using it? Counselors, therapists are very, very busy people. I'm not saying we aren't, but we're a coordinator. It's our job to make sure that we're communicating with the referral links that we have made. So it's my staff's issue that they didn't find out if the person is getting their injection. It's the other side's issue if they have a release, if we've asked and they don't let us know until the day I found out that he took, a bottle of pills, that's a problem. And so why haven't I heard about this? Um, we have a system that does allow for communication. And while there are many flaws in the system, the gap is widened when we aren't communicating with each other. It's a frustrating situation. I think you heard that I got my MBA. I got my MBA in 2022. Definitely not a youngster there. I've been in the helper field my entire life. Have degrees in special ed, elementary education, language and communication, speech language pathology and audiology. I basically do a social work role, and so I decided to go back to school for something that has to do with numbers, which I never was really good at. It was the biggest challenge of my life, and I'm so glad that I did it. So we learned about the SWOT analysis there. I really, really had to use it, although I'm sure I probably learned about it in undergrad and forgot about it. It's strengths, weaknesses, opportunities, and threats. So if we do a SWOT analysis of the connection between the DD world and the mental health world. And I know that this is suicide prevention, but let's talk about how that mental health stuff can all lead to this. A definite strength for us is that SSA services can coordinate teams. That's what we have to hear. My side, my part is we can coordinate teams. We can do a great job at that. Um, the weakness is a lot of times identifying someone with a developmental disability rules out services from the agencies needed the most. If someone in Mahoning County has both a mental health diagnosis and a DD diagnosis, the mental health board will actually tell you they're not ours, they're yours. If someone in Mahoning County is over the age of 60 and could really use some of the things that the area agency on aging does, they can't do it. They can't get it because they have DD. So they're automatically ruled out from the agencies whose services they need the most. The threat that we face is a loss of funding, a lack of trained providers, a lack of resources, and a lack of advocacy. But within this, there are great opportunities. I'm currently heading up a move to have a collaborative. I know the players in Mahoning County. I know the people who know the things that I need to know. I know the people who work in the mental health field. have excellent knowledge and resources and training and can tell me what is needed. How do I work with them? I'm huge on collaboratives. I'm huge on coalitions. It's worked with probate court. It's worked with the criminal court. It has definitely worked with the behavioral health unit at the hospital. So, developing a collaborative and a coalition that involves community agencies with knowledge in needed areas. And as soon as you say, I'm not asking you for money, I'm asking you for I'm asking you for your expertise. And when I contacted this great person, Michelle Worth, who works for the Mental Health and Recovery Board, she said people with DD can't participate in some of the trainings and some of the counseling and some of the stuff that we do because of their cognitive deficits. And she said, I don't have staff trained in DD. And I'm like, I don't have staff trained in mental health. Like, what can we do? What can you offer? The staff who directly works with our individuals needs trained in mental health work, how to work with someone with mental health issues, how to not be a trigger. You know, we've done a great deal of training in trauma informed care and resilience, I think to the benefit of our people. But if you look at the SWOT analysis, I really want to focus on the positive. We know the gap, we know the weaknesses, but we also have opportunity to work, you know, through some of that stuff. I guess that's my wrapping up. My parting thoughts are, you know, I hope that this gave you some information. I encourage you to reach out to, if you're working with people, to reach out to the SSAs. There's information about county boards, which I will include some of the initiatives from DODD. I will send that to Emily so that it can be a part of this packet. Um, I've done all the talking, but are there any questions?
That was awesome, Lynn. Thank you. It was so interesting and insightful to learn more about how we can better bridge that gap. And I personally loved the real world stories and experiences you shared because I think that really puts it into perspective. But we've got probably time for one or two questions. If anybody wants to add them in the chat, please feel free. And then I can wrap us up around 10:55 here. So I'll pause and see if anybody wants to add anything. And if not, I have a question I can ask as well. I can jump in the meantime. Lynn, I know that you mentioned that some of the smaller counties do partner up together
Mhm.
to try to work together. And I know that we do have a lot of small counties in Ohio. So I guess I'm just curious, how do we help? What are strategies we can use? What are some partnerships we could put in place to increase access to the clinicians trained in both behavioral disabilities and mental health care in these smaller areas here in Ohio?
Yeah, I guess you know, I personally, you know, I've reached out to our boards. I can send a list of those counties that pair up. I can send a list of who the contact people are. I'm actually working on that myself. One of the things that we have happening is we have other counties, many other counties in Ohio, who are sending their behavioral needs to Mahoney County. I'm just going to be honest. We're like the floodgates have opened, and we're getting people with some serious uh, behavioral health, mental health issues. So one of the things that I'm doing is, and it's an effort to be kind, not to be mad that somebody wants to move here or that it's been suggested that they come here. I'm reaching out to each county to find out who their behavioral supervisor is, who deals with behavior support. I can certainly share that list with you.
Yeah, that would be great. We can include that in the follow-up email as well for folks in case they're interested in learning more.
Yeah, super.
Great. Any questions? I'll pause again and see if anybody else wants to add anything to the chat. If not, I can ask one more and then maybe we can wrap it up. I'd love to end on a positive note, I guess. And Lynn, would you share if there's any promising statewide or community initiatives that you're seeing that are going to help close this gap, or anything that you're really excited about for the future of this space that we can look forward to as we're trying to really break down those silos?
Yeah, sure. I will say that they have now assigned, instead of just behavior, because we do meet regionally and both statewide for behavior support. They have moved it into there will be a resource person. It's going to be called Complex Needs. I'm meeting with her within the next 2 weeks. And then I have talked with our superintendent long and hard about the need for adults to have these services. And I didn't go into everything, but there's Ohio Rise, there's the MRSS, the Mobile Resource Unit, there's a lot of things for youth, but there's not a lot for adults. It's a big space that needs filled. I shared with him the request about the coalition. I'm not asking you to give money. We just want to get together and share. And so the state has reached out. There are going to be 5 counties where I guess people have expressed the same thing. So looking to I think it's a gap. If I don't know enough about you guys, I think it's a gap and you don't know enough about us. Like, how do we come together to know what each other does and not expect you to solve my problems, but how can I tap into what you know, right? So I'm excited about that. It's just in the very, very, like, I just got the email and said we're meeting tomorrow, actually, by Zoom. So I'm excited by it.
That's awesome. That's really exciting and hopeful for what the future will hold.
Hmm.
I just got a notification that the chat was not working. So if anybody wants to drop questions in before we wrap up, I can always pass them along to Lynn. Or if you want
Okay.
to share them with us via email, please feel free to do that as well. I will share Lynn's email in our follow-up email as soon
Okay.
as we hop off. So that way everyone can connect with you as well.
All right.
All right. Lynn, thank you again so much for helping us understand more about how we can bridge this gap between mental health services and individuals with developmental disabilities. Like I said, I'll be sending out that email to everyone shortly, and we'll include Lynn's slides as well as her contact information.
Thank you.
And a final reminder, if you would like a CE credit or certificate of attendance, please fill out the survey that will be coming after this webinar. It should pop up for everyone in your browser. And then finally, we hope you'll join us on November 13th for our next presentation. It'll be with Jeannie Morrison. She works with the Community Engagement and Partnership Coordinator for the Suicide Prevention Team with the Chillicothe VA. So she's going to be talking about understanding the nature of military culture, combat, and the stresses of transition and trauma-informed care right in time for Veterans Day. So thank you all again so much for joining us, and we hope you all have a great rest of your day.